Hello, everyone, and welcome. I am Rachel. I am community manager here at Alloy Women's Health. We are a telehealth platform bringing science-backed, evidence-based menopause hormonal solutions direct to your door. Today, I am thrilled to be speaking with Alloy prescribing physician, board-certified OBGYN with 20 plus years experience, Dr. Darwana Ratleff Todd. Dr. Todd was born and raised in New Orleans, Louisiana, and completed her medical school and residency training at the Louisiana State University Health Sciences Center in New Orleans. She is a decorated military veteran who served her country during Operation Desert Storm and again during Operation Enduring Freedom at Walter Reed Medical Center in Washington, D.C. She's a member of, ACOG, AMA, NMA, the Menopause Society, and recently the International Society for the Study of Women's Sexual Health, that's ISWISH. She has a passion for all aspects of women's health. Dr. Todd especially enjoys providing exemplary treatment to our aging female population, as she herself has experienced the challenges women face as they mature. Her motivation is to see all women transition into menopause with strength and grace. She is a wife, mother of 3, and a grandmother of 7. I have seen pictures. They are beautiful, a beautiful family. In her free time, Dr. Todd enjoys fitness and travel. Before we get started, welcome so much, Dr. Todd. Always so happy to see you and spend time with you. I just wanted to remind everyone that you may enjoy $20 off today using the coupon code wellness. You saw it on the banner before we got started, and it'll be put into the chat. Also, I just want to let you know I'm going to sort of get to your questions as soon as Dr. Todd gets through her presentation. Really, we're doing things a little differently today. She has a PowerPoint that she wants to share with us about today's topic, and then I'm going to get to your questions in the chat and some that I got into my DM. So welcome again, Dr. Todd. Just a pleasure always to speak with you and see your face and learn. So I'm going to turn it over to you.
Well, thank you, Rachel. You are always so graceful, and thanks for that great introduction. So what I'd like to do is it's a short PowerPoint just to kind of go over some of the things that we're going to be talking about today, but also, yes, to answer all of the questions that come in. So I'm going to go ahead and share my screen. Okay, can you guys see that? Okay.
Yes.
All right. So I call this talk menopausal hormone therapy. It's not just for hot flashes, but I wanted to go back and talk a little bit about what MHT is. Why do we even call it that these days? And how does it compare to why we call it that versus HRT? So on the agenda, what is MHT? MHT main indications, MHT and prevention, MHT and non-traditional symptom relief, and final tips and takeaways. So menopausal hormone therapy was previously known as HRT. It has been frowned upon since about 20 plus years ago due to the WHI study that came out and said that it increases the risk of breast cancer. So nobody wanted to take it. So we started, deciding, once MHT became menopausal hormone therapy, we started thinking, why are we calling hormone replacement therapy versus let's treat menopause? So that is how MHT got started. And the hormones that our ovaries traditionally produced when we were younger and had a lot of ovarian production, so I would say before the age of 40, 45, was estriol, estradiol, estrone, progesterone, and testosterone. Estradiol is the main hormone that actually affects a lot of the body processes as we're aging. Estrone is more prominent in menopause, and then estriol is more prominent in pregnancy. Of course, progesterone and testosterone are always there, and especially testosterone in lesser levels than male. Hormone tests are not indicated in perimenopause and menopause patients. We simply don't need them because we know that there is a decline in the hormones that your ovaries have made when you were younger. They are indicated for things like if you're going to do testosterone therapy, or if you have a thyroid condition, or if you have premature ovarian insufficiency, and that is if you're age 35 or less, and you start to lose your period for 1 year, then yes, we do need to do some testing. This slide kind of depicts the natural level of what the hormones look like as we age. I mean, at the age of 30-ish, we fully full, but as we go, we get sharp declines as we're aging. So this is something that I just wanted to kind of give people a chance to kind of see, because it's hard to conceptualize what we mean when we say your hormone levels are dropping naturally, but it's really kind of hard to conceptualize. So FDA approved indication. So the FDA has decided we can use hormones for these conditions: hot flashes, night sweats, vulvovaginal atrophy, which could lead to the genital urinary symptoms of menopause, prevention of bone loss, and treatment of premature hypoestrogenism. And that is if you have hypogonadism or if you have that premature ovarian insufficiency.
Okay.
So besides treatment for these, what else is there?
Right.
The osteoporosis prevention, frailty with aging, reducing the risk of new onset diabetes for those patients who don't have diabetes, increasing cognition when started early, reducing dementia, lower onset of coronary heart disease and cardiovascular disease, lowers all-cause mortality. So mortality from any reason when you're on hormone replacement therapy, it's lower. And then prevention of colorectal cancer, especially in patients who are taking estrogen and progesterone.
Okay.
So perimenopause, menopause, and mood, because this is a big one that a lot of patients will suffer from.
Yeah.
And so what they have found is that it treats depressive symptoms, especially if these symptoms have started when you started going through perimenopause. They're extremely helpful. The anxiety, especially progesterone, there is a benzo-like quality to progesterone that helps with anxiety. Irritability, same thing. Mood swings and insomnia. Progesterone will help you sleep. Trust me, I know.
Me too. I second that.
I know. So the perimenopause, menopause, and special senses. So with the skin, I put here the skin. Estrogen increases the epidermal and dermal thickness, collagen and elastin content, and improves skin moisture, reducing the wrinkles. And when the estrogen levels drop as we're aging, there's less oils and less collagen produced, leading to itchy skin. People talk about their skin itches. Why are their skin, having skin itching? Well, it's because they don't have those natural oils that estrogen actually help to proliferate, and that skin gets more dry and thinner.
Right.
Mm-hmm. Estrogen levels are directly linked to hair growth and hair loss. Estrogen binds to the receptors on hair follicles to promote that growth, and the lack of estrogen causes hair follicles to shrink and inhibits new strand growth. So this causes the thinning that we sometimes see, or sometimes patients will say, oh, I see a clump, I see hair
Right.
coming out as I've gotten older.
Interesting.
Mm-hmm. And then just as our talk, we did a cognition talk before of cognitive function and brain fog. Estrogen actually supports cellular metabolic processes, formulation of new brain cells, and synapses. It also helps decrease inflammation. So if there's any inflammatory conditions that are there, estrogen will help with that. And of course, learning and memory. And then we also have here where ear. Research shows that people here have tinnitus as they age sometimes.
Yes.
And they show that when you have higher levels of estrogen, then you can hear at higher decibels, or higher frequency. And then with that estrogen drops, that frequency is reduced, and that's where the ear ringing starts.
Wow.
It can, isn't that weird? Anyway, estrogen can also affect the eyes glands, which can lead to dryness and tear evaporation, and also lead to more corneal elasticity, causing blurry vision. So if you have decreases in the production of estrogen, you may get some of these symptoms. The one thing that I found fascinating when I was doing my studies for the MSCP was that estrogen helped prevent glaucoma and open angle glaucoma, especially in African American women. So I thought that was really kind of, a phenomena that estrogen can do that. I was really intrigued by that. And
Mhm.
then hormones and mouth health. We talk about, some people will come in and say, my mouth is so dry, or I have bad breath all of a sudden since I've been in menopause. Are they talking? You can hear them talking because their mouth
Yeah.
is still dry. Estrogen has been shown to increase saliva production, which leads to decrease in symptoms of these types of things, the bad breath, the bitter taste, etc. The other thing, and I have a patient that this happened to, and I did not even know this, but when I was going through some of my research, they say in the perimenopause, particularly, the fluctuating hormones can lead to an increase of Candida albicans in the mouth. That's yeast in the mouth as well. And
It's
these
that
people will
white
get,
tongue that people get.
yes,
Yeah.
yes,
Mhm.
they'll get thrush type symptoms. And I have a patient who went through this, and I'm like, I don't know why. And sure enough, it had to be because she was in the perimenopause, and we kind of got her hormones straight, and it kind of got better. So I didn't even know what I was doing.
I'm watching you sort of unravel all of these points and thinking this is such a helpful illustration for all of us in that it highlights and amplifies what we hear all the time, which is estrogen receptors are all over our bodies, right? And we can kind of conceive of that and we can sort of accept it, but to see all of the places where we are impacted by the reduction of estrogen is quite something.
Amazing, huh?
Yeah, it's really everything and everywhere. Go on,
It
I'm
is.
sorry.
I do agree. Totally agree. So, final tips and takeaways. Here is all the little areas where our estrogen works, but MHT is the new HRT. Hormone therapy is treatment for what we have symptoms for. We shouldn't look at it as a replacement of anything. We should look at it to treat us. There's many more benefits for our bones, our heart, our mental health, cognition, eyes, ears, mouth, skin, hair. I didn't go into the heart thing. I figured I'd answer some questions about that one. Decreases all cause mortality. That is huge because we die of heart disease mostly. And if we have a chance to start, our menopausal hormone therapy early, then we may not die from some of the things that, of course, not accidents, but stuff like that we can prevent. And if we stay well, we can continue it indefinitely. There is no cutoff time that you have to stop taking your menopausal hormone therapy.
Very
And
helpful.
last but not least, here I am with that family
Oh,
you
with your
talked
family.
about.
Yes, there you are. A vibrant, thriving,
And
youthful grandmother.
and I hope that this gave you a little bit of information, that we can run with.
Thank you. That's great, Dr. Todd. All right. I'm going to get us to questions. We have some that came in on the chat. We have several to get through that came in to me separately. And if it's okay, I'll just start running us through.
Okay. I'm going to stop sharing. That way I can
Okay.
get back. Okay. There we
Okay,
go.
great. My doctor prescribed estradiol vaginal cream, 1 gram, for me to use, but I'm not feeling comfortable about using it because I'm a breast cancer survivor. That's estrogen receptor, progesterone receptor positive, and HER2 negative. How safe is this cream for breast cancer survivors? Or could you recommend an estrogen-free product I could use? This comes up a lot, particularly for people living with breast cancer or having gone through breast cancer treatment. There remains a sort of gap between, the truth of vaginal estrogen or taking hormones at all, estrogen specifically, and their health. So could
The
you
risk of
clarify that?
cancer.
Yeah.
Yeah, absolutely. I am a guilty prescriber of giving vaginal estradiol to breast cancer patients, breast cancer survivors, even if they're estrogen receptor positive. The reason being is because there are several fold. Number one, estradiol for the vagina is a localized preparation. You will not get any systemic effect, and there is minuscule in the bloodstream that they can't even detect it on laboratory studies. So it does not increase your systemic estrogen levels to any degree to affect those changes or those cells in your breast or recurrence. So that's number one. Number two, we're using a teeny weeny amount. It is 1 gram. So 1 gram of anything that you take in terms of a cream like that, there's only going to be so much absorption of that anyways. Where it's absorbed is right in the tissue. That's what we mean by local treatment. Those tissues in that vagina only needs a little bit because they're full of receptors. So all of those receptors are going to take that little bit in. We don't use it, the third thing, by any regularity. You're not using this every day. You're using this 2 to 3 times a week, and again, a small amount. So you have time to, even if you got a teensy bit in your bloodstream, which I doubt you get, you are not using it in any significant degree to affect that being able to go everywhere else. So it is safe. The thing that I hesitate about doing non-estrogenic preparations is because most of them are water-based or silicone-based lubricants. And you can buy those over the counter. People talk about DHEA. DHEA can turn into estrogen and testosterone. So are you still not getting estrogen by using that? Not true. So the thing is, I say the ones over the counter, the preparations over the counter that are water and silicone-based, they are not going to restore collagen to your vagina. They're going to put some moisture in there. It's going to be temporary, but they're not going to build the tissue. They're not going to increase the elasticity of the vagina. They're not going to treat the vagina. So,
Dr. Todd, you're so good at illustrating, making clear, and really like getting to the finer point. Thank you so much. Thank you for that. Okay, let me turn to the chat for a moment and take a question there. Do you recommend keeping / reinserting an IUD for progesterone use with patches or a vaginal ring? Is it as effective as taking oral progesterone, or is there an age when you should no longer have an IUD?
okay. So IUD, I'm assuming we're talking about a Mirena IUD. It is protective for the uterus against endometrial cancer if you are on hormones. So if you need contraception, I think it's a great idea to have a Mirena IUD. And if you're symptomatic with your menopausal hormone symptoms, you can have your treatment with your patch or your pill. And I don't, the vaginal ring, I'm thinking you're talking about NuvaRing. If you have a NuvaRing, you don't need neither one of them because you're going to have a contraception and estrogen with that. It's ethinyl estradiol. So for the Mirena IUD, it is protective. However,
Sorry, Dr. Todd, she says femring.
oh, femring. Okay, yeah. Femring is fine. You can use femring, yeah, because that's one of the vaginal, it's a vaginal preparation for systemic hormones. But yes, you can use a Mirena IUD with femring.
Okay, great.
But what I was going to say is, if you are having problems with sleep, your Mirena IUD will not help you with that. So one of the things that, and it happened to me, so I have firsthand experience. I had a Mirena IUD forever, and I started on my menopausal hormone therapy because it worked. I didn't need protection, but I still wasn't sleeping great. And my doctor decided, take this out. You don't need it anymore. You're old. I'm like, okay. So she takes it out.
I hope that's not what she said, but okay.
She takes it out and prescribes me micronized progesterone. And all of a sudden I'm sleeping better.
Yeah.
And I'm like, wow, okay. So what I like to say is this. If you have the IUD and you have been having it and you want to start menopausal hormone therapy, you need contraception, keep it. I will also say that if you are having problems with sleep that isn't resolved with you taking your systemic estradiol therapy, and you feel like you need more, you can take micronized progesterone with the Mirena IUD. They're two different progesterones. The Mirena IUD has levonorgestrel, which is a synthetic progesterone, and it acts locally on the uterus. Once again, a local treatment. So if you are needing progesterone, I've had patients who needed a contraception like their Mirena IUD, but really needed some help with sleep. I've put them on progesterone, micronized progesterone.
Awesome. Thank you so much. That's so helpful. Okay. I feel like I'm going in reverse, somebody said. She said, which is a good thing, but it's also been weird that I'm having to shave my legs again. Is that the estrogen? Also, can progesterone cause really vivid dreams? I've heard that several times.
And I looked that up because I had never, ever, believe it or not, heard that people were getting vivid dreams.
Yeah,
I'll go back to the shaving legs thing.
sure.
But I looked that up because what they say in the literature is that they're theorizing that progesterone does do that, but there's no clear-cut evidence that that is
Sure.
the case. And, again, women's health hasn't been studied in any huge amount. So we probably could do a study on that. The one study I found was 18 patients, and
Okay.
so it was really small.
Mm.
And what they found is the progesterone improves sleep apnea.
Okay.
Yes, isn't that amazing?
Yes.
But they
Yeah.
also found that it didn't change, it didn't increase the dreams of you with your families or you with your partner. It didn't
Yeah.
increase
It was
those
quite
kinds of dreams.
different.
It didn't go into like, those vivid dreams, but it didn't say that particularly, but that is the only study that I could find on that. It was very interesting, the question. So I was really
Yeah.
interested
Thank
in
you for
finding out.
into it.
In
Yeah.
terms of the hair on the legs, I would assume since it promotes hair growth, like we talked in the little presentation, I would think that yes, you haven't had replace your hormones, something that you hadn't had at any stable degree. Yeah, your body's saying, "Woohoo! I can start, having stuff grow again and stuff
Yeah.
feel vibrant again." So yeah,
I was thinking during your presentation also that before I started using MHT, I was also losing a lot of hair, and I've not that much hair to begin with. So it was quite
Mhm.
noticeable. And I felt that after some time on MHT, so much of that loss stopped.
Decrease.
So that, yes, by far. So that was interesting, anecdotally, but really interesting. Okay,
Mhm.
on to the next. Thank you for that. Um,
Mhm.
Someone says, oh, I just saw this part first. Side note for Dr. Todd, I love your hair, your earrings, your whole vibe. And I love that. But here's her comment and question. Thank you so much for this presentation. I was a few minutes late, so apologies if I missed this, but I saw the slide indicating we don't necessarily need to measure our hormones to start treatment. But how do you know then when to start and what dose to safely use? This question comes up so often. I'm glad for it. Thank you. I'm 45 and feel that I'm starting to recognize some early symptoms. I would rather start treating now and not wait for full-blown menopause. Where do I start? It's a great question. Thank you.
This is a wonderful question and one that I get a lot on the platform as well as in clinical practice. Um, we don't need to test your hormones at the age of 45, hands down. However, what we do know is this. If you're still having regular periods, then we still know that you still have enough estrogen to provide you with a lining of your uterus to shed each month. So we know that you don't need a lot of estrogen replacement. What you need is a stabilization of your estrogen. And so there are many different ways of doing that without having you run a bunch of lab tests. Because what's going to happen is you're going to run some lab tests. I'm going to see them and I'm going to say, oh, they're all normal.
Mm.
The end.
Right. Yeah.
And you're like, well, wait a minute. I feel this. I feel this. I feel this. What are you talking about? This can't be, this is not normal. And I'll say, but these are normal. So the thing with hormone testing during perimenopause, it's normal today. It might not be normal tomorrow. It might be normal this evening. It's so we don't have any reliability with those. So that's why we don't do it. What I would suggest at the age of 45, if you're symptomatic, you're still having periods, if you don't need birth control. If you need birth control, we talked about one of the options is Mirena IUD and then using an estrogen replacement of some sort. The other option is birth control pills. People think birth control pills are strictly for birth control, but they're not. It has ethinyl estradiol, so you are getting an estradiol in it. It's a synthetic estradiol that helps with some of these symptoms, but it also is high enough, or the levels are strong enough to prevent your uterus from your ovaries from ovulating, and that is how it does birth control. However, it decreases cramps with menstrual cycles. It decreases menstrual bleeding because it binds to those receptors that make those things happen. And it also helps with decreasing the risk of ovarian cancer. So when you've used birth control pills in the past, for any reason, especially birth control, you have protected yourself against many different things. If you are finding that, okay, I'm already on birth control pills, or I don't need contraception, I really do want to start with some, plant-based hormone therapy, you are a candidate to do so. And what we do when we start patients that are perimenopausal for menopausal hormone therapy, we give them just little bits of estrogen to get started to stabilize what's going like this. And we give them progesterone, because the progesterone, we stabilize that as well. In the natural menstrual cycle, your progesterones are higher, and so are your estrogens right before your period, both drop. So what we're doing when we give you menopausal hormone therapy is we're stabilizing all of those. We're drawing a straight line instead of you doing this or this. We're kind of giving you this, kind of to settle things down a bit. And that is how it works when you're talking about those mood changes and irritability. That stabilization is what helps. So, it's kind of an enigma, like, how do you know? How do you know? Well, once you come back and say, you know what, I feel great, I don't need anything else. I know. If you come back and you say, you know what, I feel this has gotten better, but I think this is still not better, then at that point we do adjustments. But we need to wait at least 2 months, because when you adjust too soon, you may get side effects like breast tenderness, bleeding all over the place, headaches, so bloating, fluid retention. So we want to make sure that we don't affect these things right away. And so that's why we do it that way.
Amazing. Thank you so much. That's fantastic. I just want to kind of hover over here for a minute, because I'm thinking also about the comments I've seen and other questions that people have asked. As our platform, for example, has been able to amplify the messaging around the safety and efficacy of hormones. Many women who have been suffering for a long time, or certainly are on the other side of that, and sort of look back and think, well, that's, I missed that boat, and that is terrible for me and others like me. There's this sort of loud voice around, can I start today to shore up my future health? Can I start today at 43? I'm symptomatic, I'm perimenopausal, I'm sure of it, but I'm closer to 40, which is sort of this weird age where people get a little spun around about, am I ready yet? Can I start with this yet? Because we also, I think, have had this message around MHT being something for over 50, like as if there's something about that age. So to that question, I guess just a bit more, just for clarity's sake, we know all of the benefits, we know how effective it is, we know how much it kind of helps to shore us up against future chronic disease. But for somebody who's 40, for somebody who's, on the lesser side of 50 and is looking at all this, is it still a symptom thing? Or for those people who maybe are like, I'm actually doing okay, but I really don't want osteoporosis, my mother had it, can I start taking it?
So here's what I would say to that. If you are feeling fine, then you have enough of hormones that are actually preventing these things. Okay. You really don't need my support. Okay. But remember in that slide, we went from 35 to 40 and we saw that space.
Yes, I saw that space.
So that little space, tells me that, hey, I need to get you back to feeling 35 again. And so if you have symptoms, which is why we do recommend having symptoms, because if you don't have symptoms, you're good. Your body is making enough, your bones are being protected. But when you start to have symptoms, and especially if they start to get debilitating, because at first you might not realize, is this, what is going on here? I feel irritable, but not every day. It may be just a little bit. So what I'd like to say is, if you have symptoms, let us give you that little bit back, because then we know that we're going to be protecting everything else. But it isn't approved for just protection, except for the prevention of osteoporosis, or if you've had, your ovaries removed, or if, you had premature ovarian insufficiency. We can just give it to you whenever. You can be 25, we can give it to you because you're not getting. But other than that, we
so
do
helpful.
need to.
Thank you. Okay. Thank you for this webinar. Thank you for coming.
Thank you. Yes,
I've
thank
been
you.
getting eye blood vessel bursts, and no doctor, eye doctor or OBGYN have connected it to menopause. It's my own assumption. Question, will MHT help with the lack of oil in my eyes? Anything else? Is her question.
Now that's a toughie because I'm not, I don't do eyeballs, but
Right. Yeah, no,
and I have not ever heard of that. But how would she be able to answer how old is she in menopause or is she perimenopausal?
good question. We'll give her a minute
Okay.
to respond. I'm
Yeah,
going to move
because
on for a moment, though, to this question, which also came in to me privately. Can you repeat or sort of go over again the tinnitus relationship to estrogen?
so
And
yes.
may I throw in there actually also like vertigo and dizziness?
Mm-hmm. So I actually looked that up too, because I was thinking, it's all the same. When you talk about the inner ear, it
Mhm.
actually, regulates, your balance and your feelings of straight, stand up straight, all these things. And so what they say is that estrogen has receptors to increase the intensity of the hertz, the 2000. You can hear up to 2000 when you have it on board, but when you lack it, it decreases that, which they think causes the ear tinnitus, the ear
Okay.
ringing, that low, those low decibels that you can't hear as well, and that causes the ear to start ringing. But also, I looked up the vertigo thing and the dizziness thing. And one of the things that I found when we were looking up the dizziness thing was that, say, for instance, if your blood sugars are fluctuating, estrogen controls those. And if that is the point for you to have dizziness, it's going to decrease that in that way.
Okay.
With vertigo, it's the inner ear thing. I actually wrote this one down because I was like, this is very interesting. But
Dr. Todd loves to research, everybody.
yes, I love to research.
Yeah.
But they say HR, what they said, and I didn't find a whole lot of literature on how it works. But what they did say is that when patients are on menopausal hormone therapy or HRT, they do have lesser instances of vertigo. And so what that tells me, it has to have something to do with the inner ear receptors that we have. That those systems are aligned, as
Sure.
opposed to that causes us that vertigo. So and even for myself, I did notice myself, I had a lot less vertigo once I started on MHT. And of course, if you're having a lot of other symptoms that are very debilitating, that can also cause you to feel out of it too. So I think at the end of the day, I can't go into very scientific detail about it because I didn't get the question, but I can research a little bit more if need be and look it up.
That's so helpful. And it makes me think also that, again, sort of the value of working with a practitioner who's menopause trained, because it's just making me think about the possibility for needing a tweak here or there of your dosing, perhaps. I don't know.
Correct.
I don't want to throw out, but that's my
Yes,
guess.
ma'am.
Okay. Hello, I have a prescription for an estradiol patch, 0.06 milligram patch, and progesterone micronized 100 milligrams. Are there any side effects I should expect when I begin? I'm a little nervous.
Okay. Yes. Some patients will get breast tenderness. That's a huge one. Oh, my breasts. And that might tell you that it may be too much, or it may be just right. You're just getting acclimated to it. So breast tenderness, you could have some resurgence of vaginal bleeding. I think when patients are menopausal completely, that resurgence of vaginal bleeding is like, whoa, what is happening here? Something's wrong. But up to 6 months, you can have some bleeding that can happen. It could be like a period. It could be a little more. It could be a little less. It could be brown, spotting, all different variations, and it will eventually subside. So that's
Okay.
another one. But if you are really worried and you're bleeding heavily, you definitely want to visit your practitioner in person because that's hugely important. And then they could have, some people have bloating and water retention when they first start estrogen. I've heard of swollen ankles or feeling bloated when they start. That ends up tapering off. Or what I will typically do is decrease their amounts. And for all of these symptoms, I will decrease them at first and let them get acclimated to hormones and then restart them back up to what they need when they become more symptomatic. Or they tell me, you know what, I think I'm back. I need more at this time. So we try to just wait till the side effects go away. The headache. Some people will get headaches when they start MHT. Not often, though. I haven't seen that in any real huge degree. But those are the most common things that I find that I hear patients tell me that, you know what, I'm having this, that. Those are the common side effects. And again, I'll either stop them completely until their symptoms go away, and then we start half dose back so that they can kind of get that stuff in their bodies without feeling, or that medication without feeling those symptoms. And then we go from there.
Great, thank you. To the headaches, there was a question that had come in about migraines.
Migraines, yes.
This woman said, I suffer with migraines my entire life, or at least since I started menstruating. I've just started taking hormones. It's been 3 months. Any thoughts on when things might get better? I was really hoping for sustained relief by now.
So I think it depends on when you got your migraines when you were younger, how often and how frequent your migraines were, and are they still the same with the menopausal hormone therapy? If they are the same, then in 3 months' time, we would know that those migraines, if your hormones were the source of the migraines, though that was the trigger, we've stabilized those now, so those migraines should get better. If they haven't, then maybe the hormones aren't the source of the triggers, even if you got menstrual migraines, because menstrual migraines are usually promulgated by the drop in the hormones. So if you add that back, seems like you would be a little bit more stable. Now, here's another caveat to that, because migraines are very interesting. I've had menopausal patients who say, you know what, I used to suffer with migraines. I've completely gone menopausal and now I have no migraine. So I'm afraid of starting MHT. So I do agree, because, you know, I don't want to give you something that now you've not gotten migraines anymore. And obviously some of the hormones must have been a trigger. And so what I did with her is I actually started her on the absolute lowest dose of estrogen, and I halved that dose. And we started that way. She didn't get migraines. And so then we upped it to the smallest dose. She says, okay, I feel a little better. I'm not getting migraines. So what we did, I did a very diligent small dosing structure with her, so that I would not, because she needed it for other symptoms, but she was afraid that those migraines would come back. So migraines are very interesting because they're triggers, and triggers could be different things. So if you've been on it for 3 months, your migraines may not have been, you know, entirely hormonal. And that's why hopefully they have subsided or gotten a little less intense, or, you know, less frequent. But without knowing you, I can't.
Sure. No, that's so helpful. Thank you, Dr. Todd. I'm going to turn to the chat. Someone asks, and this I'm sharing this because this is a question that I also hear with some regularity. Are there studies looking at what is a beneficial dose of estradiol to help with the medical benefits of taking HRT? I'm on 0.05 estradiol patch and now have no menopausal symptoms, but wonder how beneficial is her dose overall? Should it be higher for the benefits?
Okay. So there are no real studies that say, hey, you need to give this for this, you need to give this for that, no. But I will say we try to start patients, again, based upon symptoms. So say, for instance, you come and you say, hey, I got hot flashes, night sweats, I'm moody, I have palpitations. And we say, you know what? Night sweats and hot flashes are telling me that you need replacement, but you need therapeutic value replacement. Usually that is the midline. People say, no, but that's not the lowest dose. Don't start me on that. I get that. But we are going to start you on the most common therapeutic dose that we see most patients get that relief from those things. Once you know that you've gotten relief, then what you have done is you have coated your body with the excess estrogen that your body needs. Because remember, this is unique. It's not a broad brush. We cannot paint you in a broad brush. Can't put you in a box. You are a unique individual. We have to treat you. Once we know that you have received treatment and you are feeling better, guess what you can do? You can also do other things to protect your bones. You can go and work out. You can do other things to help with decreasing diabetes, eating better, because you feel overall better. All of these things will get better. But yes, you do have enough. You don't need to have increases just for those protective effects. You do have enough. And as a matter of fact, just yesterday, I had a lady in clinic. She had a high cholesterol panel. And it was 4 months ago. I said, you know what, let me just get it. I started her on HRT. I said, I'm curious. Let's just get your cholesterol panel. I just want to see. And sure enough, her LDL went down, her cholesterol went down. And these are visits, significantly. Her LDL, her HDL stayed the same, which I was a little disappointed. But again, I don't know how she's eating.
Yeah.
So, but these things went down significantly. And I was in shock because she's doing nothing else.
That's amazing.
So,
That's
yeah.
incredible. Thank you
I
for
hope
that.
that helps. I hope that helps.
I'm sure it does. You mentioned the heart earlier in your presentation, and this person asked, she said, I saw the email about this talk, mentioned heart palpitations. Mine went away with MHT. Thankfully, it was awful. So that's really a comment. Sorry, it's not a question, but I wonder if you could just spend a minute talking about heart benefits.
So, what I read about that was that, again, estrogen receptors are everywhere. And what happens is when they are bound to those, when the estrogen is bound to those receptors, there is a kind of a calming of the heart. So those arrhythmias aren't as prominent. And so patients don't feel those palpitations. But in the other aspect, when patients are feeling bad, such as, I know sometimes if you get a little anxiety, you can get heart palpitations. Right. So if we calm your anxiety, that'll go away. If you're getting hot, if somebody's at work and they're like, oh my God, I was in the OR the other day. Oh my God, I am hot. I could feel like my heart was palpitating. It'll calm that down because of course now I'm cooler. So there's the indirect ways that it helps with that. And there's also the direct ways that it acts on the heart receptors itself to kind of calm the heart down and keep, again, it's a stabilization of hormones. So it keeps that stabilization away so that you don't get those fluctuations, because the perimenopausal patients are the ones that get a lot of the palpitations.
Yeah. Just returning back to something you said earlier, someone I see asks, so if you're on birth control, you can still take estrogen, ? Does DHEA and or pregnenolone work?
So if you're on birth control, you should not take added estrogen, okay? If you're on progesterone only birth control, so I guess I'll rephrase that. If you're on combination birth control, which has estrogen and progesterone, you don't need any more estrogen. You shouldn't take any more estrogen if you're going to just change into hormone therapy. But if you're on a progesterone only birth control, then yes, you can get some estrogen with that one. And then the second part of your question was what, Rachel?
Does DHEA and pregnenolone work?
So those are hormones that are produced by the adrenal gland. And so, typically when we're giving menopausal hormone therapy, we're giving what the ovary directly produced and directly gave you. And pregnenolone is a precursor to DHEA, which is a precursor to all of the hormones that you're getting. So for the purposes of, it's difficult to prescribe testosterone. Pregnenolone, DHEA will turn into testosterone. So for that reason, it may be beneficial for somebody to have it, if they cannot get testosterone because of the limitations, being that it's, it's a controlled substance. You need to have a DEA. You need to see a patient in person and all these things for this medication. But sorry, pregnenolone and DHEA does turn into that testosterone and estrone. So at the end of the day, you are going to get some benefits from that, depending on what you need.
Okay, thank you. Someone asks, if adding a birth control at 45, will it restart my cycle? My cycle is slowly leaving, missing several months in between, FYI, she says.
So I guess the question would be if you wanted to start birth control for birth control, but put
Okay.
it this way. If you are on an extremely low dose birth control pill, so now remember, there are different doses of birth control. There's a 10 mic, there's a 20 mic, there's a 30 mic, there's a 35 micrograms. Those are all different ones. But if you start on a birth control pill to help with symptoms and you start on a 10 mic, the likelihood that your periods will come back is pretty nil. Even a 20 mic, you may not get periods on that as well. In fact, both of these may make your periods stop even more so. The 30 and the 35 mic may increase your lining a little bit to where you do start to see periods more. So if that's the basis of your question, then yeah, you could start to have some menstruating, depending on the level or the amount of estrogen in the birth control.
Okay. Okay. Thank you. This question comes up a lot. Any thoughts on gastrointestinal health and hormones? I have had terrible gas, this person said. Terrible, she says again. It's crazy. Came out of nowhere. Will MHT help? I can't go on like this. Now, we're laughing because she's funny, and the subject of flatulence can be funny, but it's also really not. And this is quite common for women, and it does come up out of nowhere. Of course, we know fluctuating hormones and all of that, but can you get into that in the weeds a little bit about that for us?
Yeah, that one's a bit of a tough one because what I have heard, especially when first starting menopausal hormone therapy, and particularly progesterone, that you can actually get more of those symptoms.
Really?
Yes, because progesterone decreases slows the gastric motility down, and that stuff can just kind of sit there. Or does it increase gas? It does something, but it can make you have more bloating and more gas.
Okay.
And I have never seen anything in the literature, and of course, I've not read everything, that says that if you take estrogen, that also will decrease that symptom particularly.
Okay.
So here's what I think. I think that if you have other symptoms outside of that, and then you can take your menopausal hormone therapy, you can like you did, anecdotally see, hey, am I as gassy as I was? The other thing is you can also then, maybe you feel good enough to then look at the nutrition status, because a lot of times gas and bloating has something to do with the things that we eat. I know that we want to blame it on certain things, but certain food types are not in agreement with our, GI tract. And so consequently, some of those things may be looked at rather than trying to initiate hormone therapy for that.
Yeah.
Because I would hate for that to get worse by progesterone. Some people will have GI effects with progesterone. I'll tell you that. I see a fair number of them.
That's so good to know. And you're making me think of a few things. One is that nutrition is so important, and this is kind of an ideal time like no other to sort of take stock of foods you're consuming, maybe alcohol you're consuming, sort of things with a lot of processed sugar, which can create all kinds of havoc in the gut. And you're also making me think that the help that a probiotic can give, which we actually have. So I encourage you to take a look out for that. But yeah, sometimes you need a little sort of extra
And I would like to say one more thing about that constipation. If you're suffering, there are women who suffer from chronic constipation. If you are having that, again, your probiotic, I take the probiotic from Alloy. I also take fiber, and I also will look at magnesium to help decrease constipation, because that can also cause some of those excess gas and bloating. So you want to make sure that you get that under control as well.
Yeah, and helping yourself get the waste out. Somebody asks, my sister is on MHT for about 4 months and noticed she's getting more facial hair. Is that at all related?
I would assume that estrogen is one of, like I said in the talk, if it's going to help, decrease hair thinning and new follicle growth, or increase those things when you're taking it, I would think that just that alone, because it's going to make you have hair thickened everywhere else, right?
Mhm.
So I would guess those facial hairs that are there, they are probably stimulated by that estrogen that she's getting. The growth is stimulated, just like the growth on the hair of the head.
Right,
So
right.
that's why with the new product that we have, we ask patients, do you have a lot of symptomatology with facial hair? Because anything that's going to induce or help thicken the hair or help with growth of the hair, or that kind of thing, it can cause that to do that wherever you have those active hair follicles.
Okay, thank you. This comes up a lot. Can I use progesterone cream on my vulva?
Hmm.
Yeah,
I
I heard that
think,
question, but I'll
you
leave you.
know, I haven't had the question, nor have I looked that up. However, here's what I can say. I know that the vulva and the vagina has a lot of estrogen receptors. I know that. In terms of progesterone, I am not clear on that. Um, the likelihood that it would cause any harm is pretty unlikely, because again, unless you're using it every single day, slathering large amounts on it, then it should not harm you at all. But I really don't have a clear answer to how that benefits the vulva at all, because I haven't really used it, nor have I seen it in practice.
Okay, rather vaginal estrogen is the
Correct.
thing. Okay.
Absolutely.
This was part of our sort of invitation or solicitation about this conversation, was about mood swings, irritability, and this kind of everything under that umbrella. So this person asks, mood swings and feeling like I hate everyone close to me. This is very surprising to me and causes me great sadness. I just cannot stand my husband, especially. Everything he does gets on my nerves. I'm only 40 and feel like I'm too young for MHT. I also don't want to be on the pill, but I'm desperate and heard MHT can help. Do you prefer MHT or the pill for someone my age? And do you think it'll help the moodiness? Maybe I need an SSRI, question mark.
Okay. So with that question, it's pretty loaded, but I do agree that you're in that perimenopausal, that there are little things when those levels go down are going to go, they're going to affect you in ways that you don't fully understand. Why am I feeling this way? I don't understand. If you need birth control, I think the birth control pill is a great option, because with that, you can use it in a continuous fashion that you get a steady state of hormone every single day without getting a period at the end of the month, because you just keep going, or you can get a pack of pills that actually have that continuous fashion. So if you need birth control pill, it is a great option to help with those mood swings. Some women, though, when they first get on the birth control pill, have worsening moods. So that should not be a criteria for you to negate that if you need contraception. And the reason being is because there's so many different types of pill options out there that we could adjust what you need based upon, the different formulations of pills, and you can have that moodiness just completely go away, your periods go away, and then you feel much better. You might not even have other symptoms. Now, if you don't need birth control, then I would suggest that even if your periods are normal and you don't need birth control pills, or you want to do something different outside of the taking a pill every day, because of course MHT has some transdermal formulations that you can use, I would suggest that using an MHT with a low dose patch to kind of, again, just kind of get you from out of these fluctuations, to keep you at a steady state, so that you're not feeling that angst that you're feeling. In terms of an SSRI, here's what, when I did my studying for the test again, they said that if women start to have the moodiness, the mood swings, the irritability, anxiety, depression after the age of 40, and they've not really had it before, then it's very likely due to the changes of the perimenopause, menopause transition, and menopause. So we know that maybe replacing some of what we
Right.
lost may help.
First line of
Um,
defense.
exactly. And so at the end of the day, that is one criteria that we look for. If you have had depression in the past, it can get worse in menopause. If the SSRI has done well for you in the past, then you can use that again during your perimenopause and menopause timeframes, especially for those patients who have PMDD. I find that they have gotten better with an SSRI part of the time, but they need a little more when they're perimenopausal, so they can do that. But here's the other. Even if you decide, you know what, it might be my hormones, I want to get those stabilized, but then I'm just still feeling mood swings, you can use the SSRI with your menopausal hormone therapy.
Right.
It is safe to do a combination therapy if you feel like then that is going to give you the even keel that you need. You feel better. You don't hate your husband anymore.
Yeah.
You can, get along with your family. I mean, that's huge. And it's such a quality of life issue that, we need to take control of that and try to get that. And that's why I put that slide up there, because I want people to know that we have benefits for you.
Yeah, thank you for that. That's a great answer. Thank you. The woman who asked earlier about eye vessels bursting, she said, I'm 50 and started menopause at 45. The burst started at 46, and styes started soon after my period stopped at 45. Would MHT help with the creation of oil in the eye to avoid
Yes.
dryness? I started Climera Pro patch a month ago.
Okay. So that's good. I think for what you describe, it sounds like the menopause has dried your eyes out so much that you have had those capillaries. They're like dry and friable, so they're
Yeah,
just bursting. You blink your eye and you're causing friction because it's so dry. And so I think if we can provide the moisture to your eyes with the estrogen, like I said in the talk, it does help with oil production. It does help with the production of, just like in the mouth, how it produces saliva. Well, I'm sure it helps with the
sure.
tearing. So, I do think that hopefully the Climera Pro or the patch will help you going forward, not have these symptoms, and at least not with any frequency that you're having them now, and hopefully just completely resolve them as time goes on.
Great. Thank you, Dr. Todd. Okay, I'm moving us along. We're getting there. Someone said, I have seen a huge difference in my personality since I started using MHT. I love that. It's been a lifesaver and a relationship saver. Thank you. I saw and listened to you, Dr. Todd, and Rachel during a support group, and it nudged me to try hormones, not just M4. And I can't thank you both enough. My life feels like it's mine again. I'm still, I guess she's trying to lose some weight though. I know you said women need to stop worrying so much about weight. I remember you said that during support group. And it was not just stop worrying about it. It wasn't a dismissive thing. It was sort of focusing beyond the scale. But she says, I could stand to lose a few pounds. And what made me get to that question was somebody also asks about intermittent fasting. And I know those are two different areas, but for women who are struggling, wanting, perhaps needing to lose some weight for their health, and sort of parsing out the parts about the society we live in and the messages that we hear, and the aesthetic sort of focus, which is not a terrible thing if you are concerned with that as well, but for health purposes, let's say, what can you offer to women who are really wanting or needing to lose a few pounds, or are like really distracted with their weight, by their weight?
So I know what you feel, because let me tell you something. When I was younger, I didn't have to do nothing. I ate what I wanted, I drank what I wanted, I didn't work out, and I was just so skinny. And now it's like, oh,
I
and
know.
I have to tell my best friend, I have to tell myself, the scale is a measure of gravity. It's not, but
Yeah.
I see how my clothes fit and I get disgusted. So I get it. But here's what I will say. When you have a BMI of 30 or greater, then I do agree to focus on losing weight is a huge deal. And that's something that needs to be perpetuated because, we want to make sure that we're in our optimal health. And so we may need to use something in addition to menopausal hormone therapy, but I'm gonna get to that. When your BMI is 27 and you have diabetes, high cholesterol, hypertension, then yeah, I do agree that you probably do need to lose some pounds. And I'm talking about need. Here's I'm going to say need, because these are health risks that you take by being heavier. You risk the getting cardiovascular disease with this weight. And so consequently, I do think you need to focus on it. Now, in terms of those other patients who, hey, my BMI is 25, I just feel the tummy tire around my belly. Estrogen is not a medication that's going to treat the fat outside of your body.
Right.
However, it's going to decrease the visceral fat, right? And so that is the fat that lays around your organs. If you've ever had like an operation like a C-section, or if you've had a diagnostic laparoscopy, or if you've had your gallbladder removed, they look inside and see how much visceral fat you have around your organs and can tell how are you healthy with this much visceral fat, even if you're skinny, So
Right.
it helps decrease that. Again, it helps for those patients who don't have diabetes, decreasing new onset diabetes by helping you with glycemic control. It helps by the cholesterol issue that I mentioned. It increases HDL, it decreases LDL, total cholesterol. And they say the transdermal is better for triglycerides, so decreasing those. So if you have those things, it helps with that. But in terms of a direct weight loss medication, estrogen or progesterone is not that. It's an indirect way to help you feel your very best so that you can focus a little bit better on your nutrition, on your exercising, on your mental health, on your sleep, because you have all of these things that actually affect weight. Weight is so dynamic. There's so many different things, other hormones also that affect weight, that estrogen is a small part of what we can give you to make your overall health better so that you can focus on decreasing or shedding those pounds. And so again, I'm guilty, but I will say this one other thing. I love lifting weights and working out. Like when I put fitness as one of the things that I enjoy, I do it almost every day in some degree. I don't always go hard and I don't always go fast, but sometimes I'll just do some yoga or meditation. But the point I'm saying is this, because all of my body needs that. And being strong to me, being strong is the new skinny. I will say that over and over and over, because when I'm 4'11", just to let you know. But when I'm in the airplane and I'm trying to get my luggage out, somebody says, "Oh, you need help with that?" I'm slinging it down, because you know why? I want to be strong. Skinny, I want to look good, don't get me wrong, but being strong is so important.
I just got hung up
with that too.
Yes, it does. And I just got distracted by learning you're 4'11". Is that true? You're a little tiny person.
Yeah.
Oh, all right. But you are strong and you can get your suitcase down by yourself.
I get my suitcase. Yes.
Critically important. That's critically important. Thank you for that. Question. I'm 42. I had one ovary removed at age 30. I had a partial hysterectomy at age 37. I have very painful ovulation every other month, so I know I'm not in menopause yet. I started having really rough perimenopause symptoms this year and was just ordered estradiol from Alloy. How long does it take for symptom relief, i.e. low libido, hip pain, numbness in my extremities, poor sleep, etc.?
6 to 8 weeks. Yeah, you want to give it at least 6 to 8 weeks to kick in, to let those levels stabilize at the molecular level. The estrogen has to get into all of those cells. So if you're at 8 weeks and you're finding, you know what, I'm still having XYZ, and it really is good. We don't talk about this enough, but it really is good to keep a symptom calendar. How am I feeling right now before hormone replacement therapy? Putting numbers, 1, 2, or 3, mild, medium, or heavy, how do I feel on this without it? And then giving myself that 8 weeks to compare. Okay, where am I in 8 weeks now? Because at that 3-month mark, when it's time for you to get another prescription, do we need to add something? Do we need to subtract something? Normally, though, I'll get patients with the side effects, so I know I need to subtract sooner than later. But in terms of, hey, something's going on, but I don't know quite what, 8 weeks is kind of golden. And remember, we don't always start our hormone therapy right when symptoms start. We don't know that. We don't even know we don't even know that that's the symptoms of perimenopause, right? We don't even know.
That's a
But
great point.
yeah, so we've been having these things for a while. So just like we've had them for a while before we actually get medication, we can't expect immediate relief in all cases. So we need to give it a little bit of time to get into our system, into our cells at the molecular level, and start treating us like we need to have our treatments.
That's so helpful. Thank you for that. Dr. Todd and everyone here, I'm so grateful so many of you are here. I know we're over the hour, and I know, Dr. Todd, you allotted a fair amount of time, but I don't want to take advantage. So can you hang on just maybe 10 more minutes with me?
Absolutely. Oh, yeah, absolutely.
Okay. Somebody asks, this is a strange question. Oh, I love this question. This comes up a lot too. But is it a good idea to, quote, take a break from hormones sometimes? Is that the same as cycling? Should I be doing this?
Okay. So it's interesting. So if you're still having periods, a lot of people, I call it cycling when you have periods, but if you're not having menstrual cycles, there is no need to, quote unquote, cycle anything.
Okay.
You don't have to take a break either, because what happens when you take that break is those symptoms come back with a vengeance, and you're like, whoa, what happened? I only took, a couple of months off. I don't believe, and now I have to start all over. So to me, it's better to just stay where, if you are having symptom relief, just stay there.
Enjoy it. Just keep going.
Remain there. Yes. Embrace it. And maybe, focus on something else that you want to change or want to get. But honestly, enjoy life as is, because at the end of the day, staying on them will not give you that resurgence of those symptoms again.
Terrific. Thank you. I want to ask this again. You've kind of answered it throughout the hour, but just to kind of what is the range for the typical dosage you prescribe for estrogen or progesterone?
Okay. The range. That's kind
I
of
know. See, this is why I want you to answer this, because the answer is like a nuanced thing.
It's all over. Yes.
Yes.
So it does really depend on the symptoms. And I know I keep saying that.
No. That's why I asked again. I want everyone to really know.
Okay. So because we have some women who don't have hot flashes or night sweats anymore, right? But they have the palpitations, the fatigue, the other symptoms of menopause that we talked about, hair loss, what have you. And so those patients, you tend to find that those patients don't really need a whole lot of estrogen. And so we'll start them at a lower dose, just because, and the ranges, the patch comes in like 0.025. That's the absolute lowest. Sometimes I'll see somebody with night sweats, and other symptoms, but not hot flashes. I might start them at a 0.0375 patch, because I feel like, they have some vasomotor symptoms that can be relieved, but they're not really that symptomatic. Or they'll say, my main symptom is something else and not hot flashes. Or my main symptom is lack of sleep. I'll throw them on a higher level of progesterone. So it's a very, very nuanced discussion, but the dosage comes in 0.025, 0.0375, 0.05, 0.075, and 0.1 milligrams. Those are the doses of the patches. The gel also can come in those dosage. I don't think Alloy has those dosages just yet. And then the estradiol pill is 0.5 and 1 milligrams and 2 milligrams. And then of course the Evamist spray is a 1.53 milligram in each spray. So So consequently, you get a different amount of hormone, and we try to gauge, again, uniquely based upon what you're telling us that you have, in order to affect what you need. Because again, it's so hard to say, hey, yeah, everybody's going to get this, because then you're going to get side effects from some patients.
Yeah, and I'm thinking too, and this comes up a fair amount in support group, but the fact that there are different ways to take this, right? So maybe the spray is better for you, maybe the patch, maybe oral is actually better for you. And it's not just symptoms, maybe it's,
Family history,
yeah, or kind of
your
what
history.
works for you. Yeah. So
Mhm.
there are multiple options is the point. And it's again focusing on the individual.
Absolutely, 100%. I can't say that enough. I had many, many patients who want me to just give them the answer for every, and I'm like, you're unique. I have to work on it. I mean, I'm never going to do that with anybody, because I know each and every woman is different, and they have different needs, different symptoms, and we need to adjust and try to get in it. Dialogue is key. Is really just, letting us know, what that need is.
Thank you for that, Dr. Todd. All right, just a couple more. One person here asks, my labia area seems to have shrunk. What can I use to make it look vibrant and healthy again?
Vaginal estrogen.
We
I
love
love that.
vaginal estrogen.
I'm a vaginal support queen. I mean, all of my TikTok videos and everything has something about the vagina. I mean, I just think that it's a huge deal that just doesn't go, we don't talk about it a whole bunch. And the thing is we need it. It's a functioning organ, and we need it functioning. And so at the end of the day, your vulva and your vagina, and that's what's really nice about the cream, because the cream you can rub it all over.
Right, right. And
Just,
you should,
you should. You can
yeah.
put that little bit in the lower third of the vagina, and then you can rub it over all over the vulva, and it will help those tissues to thicken, and that collagen production. All of that is in that skin of that area, and it will plump that area up, make it a bit more comfortable.
Perfect. Thank you. Someone says, let's see. I actually did pretty well through perimenopause. Surprise. I'm 62 now, though, and have been feeling very, very depressed. I have a history around the birth of my children. I think she means a history of depression around the birth
Okay.
of. I really don't want to take an antidepressant. Been there, done that. Would hormones be an option for me? Is it too late to take? My period ended for good at 54.
So being 62 and 54, you're still within 10 years of your last period. And I do get it, you're over 60, but it's either or is what they say. So you're still within 10 years of your last menstrual period. This is a new onset. I know you had it with the kids, but that was kind of, I think, isolated. You weren't just a depressed person. Then you may benefit from something very low, I would add, depending on, what's in your medical history. And also, if you have no other comorbidities, such as hypertension, diabetes, don't have any other history of strokes or anything like that. So, you may benefit, but we would need to kind of, again, see what your history is, make sure that, you've had a thorough physical exam, and that you don't have any high risk of cardiovascular disease already. But the fact that you're still within 10 years of menopause, you may get some benefit from that if your symptoms are due to your hormones.
Right.
If it's due to the lack of hormones, then a little bit of hormone replacement may benefit you.
Right. Someone asks about the M4 cream, which
Yes.
a study was just done and we've released news about that as of yesterday. She said, I hope you can answer
Oh,
the question about the estradiol to the face. I use aloe's cream and curious to know the evidence of lessening lines, wrinkles, and collagen production. Now, I don't know, Dr. Todd, if you want to get into that right now. There is something I can read about that that will hopefully be helpful to this person's question, if I might.
Oh, sure.
Hang on just one second. So here is some of what's come out of the study. Sorry, I'm just trying to pull it up. Okay. M4 Estriol Face Cream demonstrated statistically significant improvements in both skin appearance and quality with no reported adverse effects or increased levels of estrogen in the bloodstream. Data from the 12-week, this is important, double-blind placebo-controlled clinical study showed, and here is the list of all that was showed, 88% improvement in skin elasticity, 70% improvement in hydration, 57% improvement in skin texture, 48% improvement in radiance, 68% improvement in overall skin health. The double-blind, three-armed, placebo-controlled clinical study of the efficacy and safety of M4 Estriol Face Cream and estradiol with M4 cream base was designed and run by an independent expert dermatologist investigator and reviewed by an institutional review board. After 12 weeks with check-ins at baseline, 4, 8, and then again at 12 weeks, the study showed statistically significant improvements in those following attributes. Let's see.
That is huge.
It is huge. I mean, it's quite something. The cream was specifically formulated to counteract the effects of estrogen deficiency in the skin due to menopause, perimenopause, and natural aging. M4 is enriched with 0.3% pharmaceutical grade estriol, an estrogen hormone, and a proprietary combination of hydrating ingredients. I hope that helps. I don't want to go on reading too much.
I do, because just like I said in that little presentation of mine, that collagen, the elasticity, the moisture, all of those things are super important. Collagen production and increased water in the skin itself to keep that moisture up. I mean, that was the first product I bought.
Stop it, really? You know, also, and I don't know if sorry, I was sort of reading and thinking at the same time, but it's very important that people know that it is not systemic. It is, again, local. So you can speak more to the science of that than
Absolutely. Because I looked into it, read into it. We were privy to get some of the, not that particular study. That's an excellent double-blinded. I mean, you can't get any better than that. And triple-blinded, you can't get any better than that. And I actually looked into some of the literature that they sent us when I became a prescriber, and I was like, oh no, I need this right now, because I felt like my skin was cracking. I live in the West and it's hot.
You're in the
and
desert. Yeah.
I felt cracked. And so I was going to an esthetician and getting facials often. And I still felt like, she's like, just drink more water, drink more water. And then finally I ordered my M4. I was like, no, let me get on this M4 because, it's a product I believe in. I started using it. And then about, a few months later, she was like, oh my God, your skin is so plump and it's so hydrated and you must be drinking the water. And I'm just smiling. I ain't nothing else.
It wasn't that. Yeah. Let me tell you,
everybody, high alloy. You need to look into it.
Yeah, it's quite something. And the studies are just incredible. It was a larger study, meaning a larger number of women. And and
I want to say something about estriol. Estriol has been shown in other studies to be beneficial for the face. So undoubtedly, because again, we talk about the receptors, but there's different types of estrogen receptors for different areas. And it seems like the estriol receptors are more prominent. They have more of them in the facial structures as opposed to intravaginally. So that's why you can use them, and you can use them simultaneously with your systemic menopausal hormone therapy. You'll just get that much more enrichment to the face. But I think it's great. I love my M4. I travel a lot. When I don't have it like packed in my bag already, I'm like, God, where is it? How can I love you? Freaking out like,
Dr. Todd, before I let you go, is there anything, we covered a lot today. There was a lot, to go over, and I thank you for all of the sort of back work that you did to prepare us for today. And I don't mean to put you on the spot when I ask this, but as you're sitting here for an hour and 20 minutes, is there anything that you particularly want to leave us with? Anything that somehow we may have missed? That's especially important that you let us know.
So yes, I think when you think about hormone therapy, it has gotten a very bad rap for many, many, many years. And I'd like to say this because I'm a doctor who was trained before the WHI. So I treated women with hormone therapy pretty consistently. And guess what? And you know why we didn't know about all these other symptoms of menopause? Because those women didn't have them. They
Mhm.
didn't have them. They were already on their menopausal hormone therapy. They
Right.
came in, they said, "Oh, I have hot flash. Here you go." We gave them the medication. They got their hot flashes treated, and I'm thinking treated everything else because they didn't come back with regularity, with palpitations, with ear ringing, with you know, their joints aching. We didn't have that. So of course, once the WHI study came out and then that happened, then oh, now wait a minute, what's going on? Why are women suffering like this? We don't
Yeah.
understand. Well, it was simply because the ones that had started patients on hormone therapy beforehand and then transitioned into, I won't take it, because you could offer it to patients, they wouldn't take it.
Right.
um, then you finally learn. I did not even know because I suffered in perimenopause myself. And as I have learned more, I'm like, oh my God, I had that years ago before I started hormone therapy because I didn't realize my joints. I would wake up in the middle of the night, oh my God, my knee hurts. Not, I thought I had Behçet syndrome. I'm going through every list of things and understanding that all I needed was some hormone replacement to stabilize my hormones. So I hope that this gives some patients some reassurance. Is it safe for everybody? No, there are a small portion of patients who have small things, some big things that cause them not to be able to take it. But overall, it is a very safe and effective treatment for menopause. And so if we're going to do right by you, all of us physicians need to understand the importance of treating women the way that they need to be treated in order to feel their best selves.
Thank you so much, Dr. Todd. I love speaking with you. I know I'm going to see you again in support groups. Those of you
Yes.
who were here today or haven't met Dr. Todd before, please look out for a support group that she'll be joining with me in the future. They are wonderful ways to spend the hour. She gets really into stuff, and we just love it. And you'll be back for future webinars, of course. Thank you all who came today. And finally, let me just repeat this code to you for $20 off today. The code is wellness. And I leave you all to be well. Thank you
Thank
so
you
much
again for
again.
having me,
Oh,
everybody.
it's a
Thank
pleasure.
y'all.
Thank you. Bye, everybody.